I want to first introduce the seminar for this fall semester. Just want to go through some bureaucratic elements. This seminar today is not being broadcast live because of some technical difficulties with the internet in this room, but it is being recorded and will be available probably by tomorrow morning. So anybody who's interested in the subject is more than welcome to review the seminar afterwards. A couple of things. There are about a dozen students who are taking this seminar for credit. In order to receive credit for the course, you must prepare a summary of the seminar presentation of 7 seminars. You must attend 10 seminars, which means that we are offering seminars every second week. So it's today and then every second week subsequent to today. All those seminars do count. If you miss a seminar for whatever reason, you please have to let us know, but you will still have to prepare a summary of 7 seminars. And we want you to participate in 10 seminars. Could be in the electrical engineering department, computer science department, mechanical engineering department. They all have their own seminar series, but they have to be seminars related in some fashion to intelligent transportation systems. I know in mechanical engineering there are at least 2 seminars that will count. I haven't looked at all the different seminar series, but the problem is that they don't post the titles of these seminars until this week, and even this week there are some blank spots as to what the subject matter is going to be. So anyway, there's much more detail in the syllabus. I don't want to go into the details. The seminar series is open to anyone and everyone who wishes to attend. Either you can monitor it or watch it in here, or usually it's live on the internet, but I'm afraid today we have some technical difficulties. I am very pleased to welcome our opening speakers today. Actually, it's a tag team. Dr. Johnell Brooks will be the speaker. She's an assistant professor of psychology at Clemson University. Her specialty is human factors, and she's I must say, a very amazing individual, and I think you'll get a sense of that from her presentation. She will be joined by Natalie Duran, who is an occupational therapist working with Professor Brooks, and they both are engaged in all sorts of activities, but I won't embarrass them by talking about it. I'll let them embarrass themselves. So anyway, without further ado, this is going to be very interesting. Dr. Brooks.
You get an A+ for saying Natalie's name right.
Well, very well.
So I'm a human factors psychologist in the psychology department. But because of the interdisciplinary nature that we do, I have a lot of fancy titles, and really the only reason for that is it allows us to do the work that we're doing. So I'm based out of the psychology department, but I also live in an automotive engineering department. And then Natalie's at the Greenville Hospital System, and then the other hospital that we work with is about 2.5 hours away. So a lot of the programs that we do, we start at the university, then we move to one hospital, and then we expand from there. And these are the different institutions that we work with. Are you going to get up there? Okay. So first of all, we're enjoying the cool weather, and some of you, if you don't know where South Carolina is located, we are way down here where it stays nice and warm. And last year we were very excited because we had 4 inches of snow, and because of those 4 inches of snow, I was out of work for an entire week because they completely shut down the university and just about everything else in the upstate. Okay, so within South Carolina, Natalie is in Greenville. I'm in Clemson, which is about 45 minutes away. We are a land-grant institution, so that means we are out in the boonies and there's nothing close to us. And then the other hospitals that we work with are in Columbia and then down in Charleston by the beach. So because of the state budget cuts over the last several years, South Carolina has started a new program called Centers of Economic Excellence. So what they're really doing is investing their money into areas that have economic and research potential. And so everything that we do is really expected to be something that's going to be commercialized, or in our case, something that's going to be implemented into the hospital settings. So the one that I work with the most is called Senior Smart, and that's really focusing on aging adults. The other one that we work with is called CUI CAR, and that's an automotive engineering facility. So within Senior Smart, there are 3 focus areas. One of them is smart home technologies, one of them is smart brain technologies, and ironically the one that we work with is not showing up on here, and that is really looking at smart cars. So why focus on seniors? In South Carolina, about over a quarter of all of our drivers are seniors. Nationwide, it's about 15%. By 2025, this is expected to be about a quarter of all drivers, so that's about where we are right now. And the reason that South Carolina is really high is, first of all, we don't have snow, so people like to come to the south. But also the people who grew up in South Carolina typically stay there instead of moving somewhere else after retirement. So one of the things that's really interesting about seniors is that they typically drive the fewest number of miles, but they have the highest fatalities. And it's not the same kind of issues that happen with our younger drivers who are learning how to drive, but a lot of times with our seniors, they're going to be in a very small collision, and they're going to have an injury, and they're not going to be able to recover from that injury the same way young folks are. So a lot of it's just the fact that our seniors can't bounce back, and they might break a hip, and it's just not necessarily immediately die because of a crash, but within a couple of months. So some of the characteristics of our drivers. We have essentially zero public transportation. We're a very rural state, and there's bus systems within the 3 big cities that stay right in the downtown areas. So because of that, 90% of all trips made by South Carolina seniors, so anybody over the age of 65, they are driving themselves and their own vehicles. 3% use public transportation. And then the other thing that's a really huge issue with seniors is we talk about how they're transportation disadvantaged. And what I mean by that is that they have fewer kids, their kids live further away, their daughters and their daughters-in-law are working, so they don't have the ability to provide transportation to their mothers and mother-in-laws the way that previous generations have done. And one of the interesting things that we see in the clinic is there's usually a lot of hostility between the women of the family because the moms were nice and they did that for their moms and their mothers-in-law, and they're really frustrated with their daughters and their daughters-in-law for not providing that same kind of service. Even though they understand, they may live further away, they understand that they're working full-time, but there's still a lot of hostility a lot of times towards that. So it's not only the driving issues that we deal with where the person is actually in the car, but there's all of these social issues that we deal with a lot too. And quite frankly, most of the time that lands on the daughters, not the sons. So what are some of the contributing factors for fatalities with older drivers? First of all, failure to yield right away. Driving too fast for conditions. This is not something we saw a couple years ago, but it's something that we're seeing more and more across the United States. So we're not sure if it's a fact that this is just a different generation of older folks and they like to drive fast like everybody else, or if it's a fact that the roads are more congested and they just have to drive fast. The next one's disregarding signs and signals. Running off the road is a huge problem in South Carolina because Mike was telling me how your shoulders are big enough for buses to drive in Minnesota. Our shoulders are big enough to stand, maybe if you're lucky. So in South Carolina, we have very, very, very narrow shoulders, and because we love our hardwood trees, there's usually this much room for a shoulder, this much dirt, and then this is where your hardwood tree is located. So when you run off the road in South Carolina, it's usually a nice hardwood tree that slows you down. So it's a very different issue than what you have here. Running off the road is also a big problem in a lot of our tourist areas where we have a lot of tourism down by the beach and up in our mountains. So that's an issue that we have that's very location specific. and then finally under the influence. Now, I am not suggesting that our seniors are going downtown and boozing it up with all of you and then getting in the road and driving home. But the issues that we're really seeing there are medications, medication interactions. When our seniors come in for their checkups, they're not just coming in with a little Ziploc baggie of medications. A lot of times they will come in with multiple grocery baggies, and it is not uncommon for them to come in a suitcase that you would use as a carry-on full of their medications, both prescription and over-the-counter. The other thing that we are seeing a lot more of is with electric vehicles, especially in gated neighborhoods, where they think they're being very safe driving an electric vehicle, and they will take that electric vehicle down to the clubhouse to have dinner, and they'll have a glass or 2 or 3 or 4 or 5 of wine, and then they will drive home, but they are driving home on the same roads as the cars. So when you have golf cart versus car, it's not a pretty situation, and especially because there's not seat belts or airbags or anything else in those golf carts. So that is definitely a growing problem that we're having in the South. The program that we have is really built around existing infrastructure. So Natalie is an occupational therapist, and she's a generalist, so she works with a lot of different patients, but then she also has specialized training working specifically with driving. So she does a lot of things with both teaching people how to drive who are new drivers who have disabilities or who have ADHD or maybe Asperger's or something like that. But then there's also a huge issue with driving with our older folks, both with kind of the natural decline of driving, but also folks who've had injuries or who've had car wrecks and need to return to drive. So I'm going to turn it over to Natalie, and she's just going to walk you through the process that she uses to evaluate drivers.
Well,
you have to use your mic because of taping it.
I'm loud enough. No?
But they're taping it?
I'm usually loud enough. So our evaluation is split up into 2 parts that we do. We get a referral, and people come in expecting to do for driving. So the first part of it is a very general OT, occupational therapy evaluation. We look at their functional strength, their endurance, their cognitive capacity, their visual perceptual abilities, all those things. We do it in the clinic. We even do a battery of neuropsychological evaluations to look at how they can react and how their cognitive executive functions are. So we do those in the clinic, and then we take them out after that.
So you're going to go through the 3 kind of physical...
Okay, okay. Oh, I wasn't following. I was kind of going off. So what we do, the pictures there, we'll do everything. First, the physical, we'll look at their range of motion, so how they're moving, being able to actually manipulate the steering wheel, the pedals, so we're taking a look at all of that. We're taking a look at their sensation and coordination. So sensation, really important. We have a lot of patients with peripheral neuropathy, so they will have difficulty feeling those pedals. And this is a growing concern that we now have with the increase in diabetes and things like that. Then when we go into the cognitive evaluation, this is where we do those battery of tests where we're looking at executive functions, their visual processing, memory, their attention span. So how they do that whole hour-and-a-half evaluation is quite telling to us. Everything that globally they'll be able to do in the car. Okay, where are we? Okay, the perceptual motor evaluation, how the one that you see on the left is called the Benton 3D block design, and this is to look at spatial awareness, so how your vehicle fits within the lane and things like that, so how you interact with that vehicle. The one on the right is a reaction timer that is commonly used. It has a little gas and brake pedal, so we get to see their reaction time. And for a lot of patients, it's kind of our first indication if there's a big problem, if we do or do not want to take them out into the vehicle to then look further. One of the major things that we look at, obviously, visual acuity, their visual field evaluation to look for that peripheral vision, which is really important. And there's other tests that we kind of go on with the visual stuff. The next part, if they've done well in the clinic, then we take them out on the road. We have a 27-mile course that we do with all of our patients. We start out in the neighborhood so that they get used to the vehicle, because it is a vehicle that we have at the hospital. We have an instructor break so that I do have control a little bit over what they're doing. So they get used to the vehicle, and then we take them out into a downtown highway, interstate driving, so they get to try all the different settings within this vehicle. We do, the test usually lasts about an hour and a half, and we do give them chances. So if there's things that we have seen, especially in the clinic, that they might be doing wrong, we'll cue them and we give them a chance to adjust and to modify their abilities. So a really good way to see how overall they do.
Good job. So they had this program for about 15 years, 20 years actually, about 20 years?
20.
And so one of the things that's really interesting right now is that it's a field that is really small, and some of the reason for that is it's a service that people have to pay for out of pocket. So it's not something that your insurance or Medicaid or Medicare will bill for. One of the reasons for that is there's not objective feedback for the therapist to give a patient at the end. So all of the, whenever you go to the doctor, they always give you some kind of a report, and it's because of that report that a lot of times your insurance company will pay for that. So one of the ways that we are working really closely with engineers is to figure out how we can instrument the vehicles that the therapists drive, so that we can start to give them that very objective feedback. So that's one of the things that we're doing. And we have a Toyota Avalon, and because of the nature of what the context that we're using it is slightly different than the instrumented vehicles that you have here. So we have 8 cameras, and most of those are really looking at what's going on in the environment. So one forward, one back, one left, one right, one left side blind spot, one right side blind spot, one specifically on the feet, and one that's really kind of focusing on the torso up. The reason that that's really important is because there's a lot of times if you have a patient who's having cognitive problems that you're going to experience something in that drive, and when you go back to the clinic, they're going to look at Natalie like she is absolutely nuts when you talk about that driver who almost T-boned you. So the first time I ever went out and I sat in the back seat, and I know why that little bar is on the back of the passenger seat now. That's the holy moly bar that you're holding on to when you're in the back seat of a driving evaluation car. And if it wasn't for the fact that the therapist had that second brake, I would not be standing here today. I would be 6 feet under. And it's because we almost got T-boned, and the driver never saw it. And the reason for that is when we started off in the neighborhood, the driver did a beautiful job of looking all the way around, and as the driving environment got more and more complex, somehow something magical happened to this poor person's neck, and they were not able to turn it anymore. So when we went flying through that intersection, they never turned their head to see that car that was about to nail us. And really, we had this person pull over. They never understood why we had him pull over. They thought we were absolutely nuts. But if we had an instrumented vehicle, then we could go back in the clinic and show them that, you know, in fact, we were 3 feet away from the grave. And there's that kind of situation, but then there's also the complete and total flip side. Unfortunately, it is not uncommon that when a little lady turns 85 years old, that the 45-year-old son comes flying in from California, takes them to the gerontologist, and informs them both that mom needs to stop driving. So we also need to have the ammunition to show the adult children that their parent is driving just fine. So it's not that we're trying to design stuff to take away older adults' keys, but really using it for both sides of that. Another reason that this is really important is when somebody has a traumatic brain injury, a lot of times they don't really understand what's going on in the driving environment, or that they'll kind of forget about it. So if we could show them what's going on in the drive and then have them come back and watch that and really talk about that in the clinic, and you can kind of watch that video over and over, that would be a really helpful way to get these people back into driving. So our motivation of having an instrumented vehicle is probably slightly different than how you guys have typically used it. And we do have all of that scary engineering stuff that neither one of us can begin to understand. But thanks to all of these gadgets, what that gives us is the ability to really be able to sit down with our patients and show them all of these different videos and having that really detailed map. So from a therapeutic perspective, those videos are really the most important point. And we do have something in that car, the holy moly button that they can press, so it's really easy for us to go to that point. What we decided what we really need is a pad in the driver's seat, so when they go up 3 inches, that's what we could use. So because of that, and because of watching them and kind of thinking that was kind of funny, the other thing that we've done is we've put sensors on Natalie's brake. Your instrumented vehicle, since you have completely fine, healthy drivers, there's no reason to have that second-hand brake. But with all of our at-risk drivers, we absolutely need to have Natalie have the ability to stop that car. So anytime when Natalie uses her brake, then we automatically put a trigger in our data, and that is the first thing we always look at because that's the juiciest data we have. We have really detailed maps. Really similar to what you guys have, where our civil engineering friends have gone out and used their fancy dancy van. And then they had our civil engineering graduate students had the joy of coming back and geocoding all of this. Where this one is important for us is really starting to make maps for the therapists and the patients. Some of the things we're working on right now is how do we take those incredibly complex civil engineering maps that make sense to engineers but do not make sense to anyone else on the planet. How can we take those important characteristics about roadway curvature, about hills, about how many lanes there are, about what kind of traffic control devices, and how do we put that in a way that's going to make sense? And when you think about the reports that we make, one of the things that was incredibly shocking to me is if you want to have a new report now that is going to be used for any kind of Medicaid or Medicare, it has to be on a 6th grade reading level. Holy moly. So to get that kind of very technical information in a way that's going to be represented, what we know we have to do is make a lot of this very visual. So what are the right kind of icons that we need to be able to do that? So some of our civil engineering grad students are working with us on those kinds of projects. They have a laser, and this is one of the things that's really helpful of kind of helping us make that link between what's going on in the on-road world and to our simulators. So this was the first driving simulator that we had. We don't have this one anymore, but the reason I like this one is because you know this is South Carolina, because like all good cars in South Carolina, it's sitting on cinder blocks. Oh, come on, that's funny. I don't care what you say. So this is the simulator that we have now. Really the reason that motivated us to change is the fact that since we do so many older driver projects, what's important to us are left-hand turns and merging. And when we would use this simulator for a left-hand turn or a merge, you would look out the window into our junk room. So it motivated us to get a wraparound simulator. So we could do a lot of those issues that were important for older drivers. We have 2 of these. We have one in the psychology department. We also have one in the geriatrics department. These are some of the kinds of studies that we've done. We've done a lot of stuff with visual impairments, cell phones and texting. Because of the fact we work with older populations, we had to do a lot of work with simulator sickness to really develop the training protocols that would work for these at-risk populations. Some of the projects we've done in the clinic is looking at patients who are on radiation because of all of the sickness issues that they have. What are the issues with that when they're actually driving? And that was especially interesting looking at people who are sick with simulator sickness in a driving simulator. The head and neck movements, and that was really motivated from being a passenger in the back seat, realizing the degree to which people stopped turning their heads. So putting motion trackers on people's necks and really figuring out when they stop turning their head. We have a project that was motivated by our orthopedic trauma surgeons, and that was because they would have older guys come in who would have a right knee replacement, and for their 2-week doctor visit, they were driving themselves there. How are they doing that? Using their left foot. So, but there's not really any literature that says whether that's a good idea or a bad idea. So we have done some work on that to really help them give better information to their patients. And then also functional object detection. So just when somebody's scanning their visual environment, what kind of information do they pick up and what kind of information do they miss? So in a research setting, this simulator worked incredibly well. In a clinical setting, the simulator did not work so well. And the reason for that is that it's big, And so if you think there's space issues at a university, you haven't seen anything until you're in a hospital. Space issues are just crazy insane. The other thing is when the therapist would come in, they have zero interest or time in developing their own scenarios, figuring out how to analyze the data for those own scenarios. What they want to do is they want to come in with a patient, they want to hit one button, they want to put that participant in the car, and they want to start. So it just wasn't something that made sense. So because of that, we've partnered with this driving simulator company to make a simulator specifically designed for a clinical application. So this is the one that we started with, and some of our early research was just figuring out for a clinical application, how many monitors should we have? Should we have one big one? Should we have some small ones? How much visual compression should we have? And this, again, isn't necessarily what's best for a research study, but what's going to be best for a clinical application. So we looked at different visual field compressions, and the one that we thought would be absolutely insane, 110 degrees, when we squished that into our 65 degrees, that's actually the one that our older adults were the most comfortable with. And for us, it was also really important because we could do intersections. If you have less than 110 degrees, it's kind of terrifying driving in a simulator because you have no idea if somebody's going to come at you through an intersection. And you certainly can't tell if somebody's 5 miles away and if they're going to run something, but you can tell when you get up to an intersection if there's cars there or not. Then we did a lot of usability testing to really figure out what are the components that are the most important to have in a simulator in a clinic. Now this simulator for us works really well in a clinic. It is not at all what a mechanical engineer would want to test different things because we have a lot of aspects that are designed for this to make sense for a clinic but are not realistic at all for a car. So the way that we would do this is we would fabricate a sim, we would test it out ourselves, we would bring in university students and see what works and doesn't work, and then we would make changes, and we'd start that process again, and the next time we would bring in very healthy seniors, we'd find what works and what doesn't work, we'd make changes again, and then we finally got to the point where we started bringing in patients. So some of the things are just like, you know, you want to hit yourself in the head. Like, you know, you only have to carry up a simulator up a flight of stairs one time before you need to realize it needs to fit into the elevator. You only have to carry it one time before you realize it needs to have some wheels. So some of those were like the yeah, duh kind of things, but a lot of them were issues that were really senior specific. So we need to have something that looked like it was a physical mirror, even though it really wasn't. We needed to have a really good stereo in it, so we have a Bose stereo, not because they're going to be listening to Eminem, but because they need to be able to hear those verbal commands, and they couldn't hear them if it was a cheap set of speakers. With our input buttons on the steering wheels, never, ever, ever had problems with them in the university, but when we had seniors, they would push them a million times because since they couldn't hear them click and they couldn't feel them click, they didn't know that any data was actually being recorded. The seat range was a huge one. So in most driving simulators, you want to have a really awesome racing seat. That is absolutely the worst seat you want to have for a clinic because it is really uncomfortable for our patients to sit sideways on one of those. So think about sitting sideways on one of those and how much that's going to hurt the back of your legs. And if you think about these people who have recent wounds and maybe an amputation of how painful that's going to be. So instead of having a racing seat, which is what you'd normally want, we have like a big, gigantic love seat that's a bus driver seat. So it's really wide, it's really squishy, it's really easy to transfer from a wheelchair into this. But we also have to be able to handle bariatric patients. So if you've seen those gigantic wheelchairs that look like a love couch, you have to think about how we have to handle those same kind of patients in our driving simulator. The other thing we have to do is before we can start using this with patients, we have to be able to prove to Natalie's boss that the physicians will refer their patients and the patients are willing to come. And because there's not just one kind of physician we work with, we have to make sure this is going to work with a really broad range of physicians. So we met with a bunch of them, and what we really asked them, it boiled down to two questions. Number one, are you willing to refer your patients to a driving simulator program for therapeutic purposes? So what I mean by that is rehab. And then the second one is, would you refer your patients to a driving simulator program to have their driving assessed? So I think this is about the scariest data point I have ever seen in my life. And the reason for that is that the physicians were willing to refer their patients to decide if somebody should drive or not drive, but not a one of them asked, is there any research to prove that a driving simulator is appropriate for that? So it was really important for us to have that information before we started to go and talk to the physicians about this, to really let them know what's appropriate use of a driving simulator at this point in time versus what's not. So because of that, we're very careful to talk about how the driving simulator is something that we use for rehabilitation purposes, not fitness to drive. So the physicians were willing to do this. The next step was to really see if the seniors were comfortable with this. So since we've done a zillion studies having seniors drive simulators with our big ones, what we really did is we just had them come in, sit in a sim, we talked about it, we talked about kind of the capabilities of a simulator, what we can use it for, what we can't. We showed them a bunch of different screenshots of just different kinds of settings. Of residential settings, of rural settings, of urban settings, nighttime settings, things like that. We brought in over 170 volunteers. This is kind of the target population that we typically see, between 50 and young 90s. And what the seniors were very comfortable with was the idea of using a driving simulator as a rehab tool, but they were not comfortable having it used as a fitness to drive. Should they drive or not drive? And that's the exact same way that the therapist felt. So this is also more ammunition for us to take to the physicians to make it really clear about what is the appropriate use of a simulator and what is not the appropriate use of a simulator. So what are we doing now? We had to develop a lot of training and adaptation scenarios and develop in a way that if you're going to use a simulator just as a rehab tool, so there is nothing wrong with having a 7-year-old get in the simulator and use it to work on coordinated muscle movements. Now, I'm not saying that they need to drive, but they have video games. There's nothing wrong with using a simulator as a rehab tool to work on a variety of gross and fine motor skills. So we had to make training scenarios to get people ready to whatever level that they were going to use. The functional object detection, this is one of our examples of something where we can program it and set it to what somebody needs. So if you have somebody who's had a horrible accident and they're just getting back into driving and they need to work on their visual scanning skills and you want it to start off really easy, we can have it start off that way. And then we can make it more and more complex till you have like 40 little target locations up here where it's going to be an E and you only push the button if the E is facing up and not when it's facing left, right, or down. So just having a lot of flexibility for the therapists. One of the projects we're doing with the engineers right now is figuring out the best way to train people how to use hand controls. So hand controls is the adaptive device that you use where you operate your gas and your brake using some levers next to your steering wheel if you've had an amputation or peripheral neuropathy. And the issue with that is you can't really feel where your feet are, so they have to use their hands. So right now, if you have an injury and you lost your legs, you would learn how to use your hand controls by driving on the roads, which is kind of terrifying. So what we're using this for is to just figure out how we can get people to get to the point where they can really operate the gas and the brake using a simulator first. Once they have that down, that's when Natalie really intervenes and takes them out on the road. Some of the other things that we're doing is we're making sure that the clinicians have the tools that they need to start really talking about driving. So this next one isn't something that we made. It's called the Driving Preference or the Driving Health Inventory. It's something that Lauren Staplin developed with some NHTSA funding. And what it's really nice for is to give clinicians tools to start talking about driving. And one of the things that we use it for in the research setting is it's a very easy to administer tool, so we have information about people's cognitive skills but also their visual information. So what we measure, first of all, it's used by a touchscreen. So we do have a lot of patients who come in and have never used a computer. So they just have to touch the screen and they have some practice using that. Then we measure high and low contrast acuity. High contrast acuity is if it's a dark color letter. Low contrast acuity is if it's a light color letter. They just tell us which one's facing the wrong direction. There's a short walk. So you walk 10 feet, you turn around, and you walk back. There's a head and neck flexibility. This is the one that they hate. So you have them sit on their hands in a chair. Natalie will tell them when to turn. They turn their head, and they look at the screen right behind them, and they tell what the gigantic shape is. And this is one that a lot of people fail, but it's also one that there's some really easy, really cheap solutions for. And by having an occupational therapist do this, then she can tell them exactly how to fix that problem. Working memory, we give them 3 words. A while later, we ask them what those words are. Visualization of missing information. I call this my engineer detection task because engineers always take forever on this one and they completely overanalyze, which is kind of funny, which I guess I shouldn't say in this room. But it's just really figuring out which one of these 4 designs is plausible and which one is not. And this is a harder example of that. The reason that this one is important is so it's visualization of missing information. So how can you quickly look at a situation and tell what's appropriate or what's not appropriate? So where this is important in the driving context is if there's a pedestrian standing there, if there's some kind of a road hazard that shouldn't be there, can that person kind of pick that information up? The next one is called the useful field of view. What this measures is both your focal vision, so what's right in front of you, and your peripheral vision, so what's out here. So what they have to do is tell us what's in the little box and then where on the outside of that circle that car or truck is. And then the last one is called the trails, and this is like a connect the dots. So again, this is looking at how well people interpret a big area of information. How are they scanning that information to be able to connect those dots? So these tools are some of the best predictors of if older adults are going to be involved in an at-fault crash. So this does not tell us if somebody should drive or not drive, but what it gives us information on are what are the kind of risks that somebody's going to have, whether it's a low, a medium, or high. The really nice thing about this is if we start using this with people in their 50s and 60s, then it starts to get them to think about driving and the fact that they need to be proactive about their driving the same way they are about everything else as you age. And it's a really nice way to get people introduced to the driving rehab specialist. So it's something where you can talk about how can this person help me instead of how can this person take away my keys. We had to do the same kind of thing with this. We had to get information from a ton of people before we started using this in the clinic. And so I think one of the really interesting things here is we got information from over 360 people who lived in the community, and we recruited what we thought were disgustingly healthy people. Only 17% of those people had no impairments. So that was a big eye-opener. I don't think necessarily for the clinicians, but for the research team, you know, these are the best people that are out there, and to realize of just kind of how prolific some of these problems are was pretty eye-opening for us. The other thing that's really nice about this, and I think is important, is that, you know, regardless if people had no impairment or if they had more than one impairment and we just glumped all those people together, is that they do see the connections between this and driving, and if they have a problem with any of these, they get a really nice description explaining what that test, how that test really applies to driving. Do they think it should become part of the licensing process? Oh my gosh, no. Which is the same kind of thing of what we see over and over. The older adults really want that to happen on the medical side, not at the DMV. One of the things that was exciting for us is the fact that, again, these very healthy older adults, they were willing to think about what kind of rehab, what kind of training that they could take if they did have some kind of problems to bump those skills up. And our ultimate litmus test for introducing something into the clinic is, are they going to go home and tell their friends that it was not horrible? Is it something that they would tell their friends about and say that it was helpful? And for this is one of the strongest things we've ever had, is it was a really nice way to get older folks to start thinking about driving. So where we are right now is we've completely implemented this into the clinic. And I think one of the most important lessons for me is we've been using this for several years on the university side. And we had this process that worked incredibly well. And it is just so amazingly different the second you step foot into a hospital. I think some of the examples of that is we always had our patients or our volunteers stand and do the eye charts, and we had them stand for a lot of this stuff, and it was never an issue. And then when you get into a clinic and you have these folks who have walkers and who use wheelchairs, and just kind of the difficulty of implementing anything into a clinic was just really eye-opening for us. And I think that that's something that we all really have to keep in mind as researchers of even if we have older adults come in to the university, it's a completely different ballgame the second you step foot in a hospital. One of the other things that's really important to us is being able to talk to drivers about their functional status both in the vehicle and outside of the vehicle. So since I started in the geriatrics department, I knew that our patients wanted to go have their appointments at either 9 o'clock in the morning or 2 o'clock in the afternoon. So they would go in first thing in the morning, or else they would go home, they'd have lunch, they'd have a little rest, and then they'd go in. Nobody wanted to go in about 11 o'clock. And really the reason for that is everybody wants to go at peak performance. So it was really evident to us that we needed to have a way to talk about how somebody's doing both in the car, but also how they're doing in the bigger picture. So what we found is a Homelab assessment. This is not something that we developed. It was actually developed by an exercise physiologist. Her name's Elaine Kress, and she used it to really determine if exercise programs were appropriate and effective for older adults. One of the things that's really fantastic about this is it gives us information about the functional capacity for people to live independently. So they do 10 tasks of everyday living. First one is you carry a pot with the amount of weight you're comfortable carrying from one counter. You walk a couple feet, you put it down somewhere else. From a driving perspective, this tells us if can I carry a casserole from my kitchen and put it in the trunk of my car. Next one is putting on a jacket. Putting on a jacket is the exact same range of motion you use for putting on a seatbelt. Some of the other ones, picking up scarves. So if somebody drops their keys in the parking lot, can they bend over and pick them up? Reaching up and getting something off of a shelf. So can I close the trunk of my car? Some of the other ones, it's harder to tell the driving component, but they're sweeping the floor, getting up and down off the floor. We have had people come in who have not been on the floor in 50 years. 50 years! And this happens more frequently than I would ever have imagined. So in that kind of a case, they're not going to be comfortable getting down off the floor, but by the fact we're doing this in a hospital, we can show them the right way to get down on the floor and make sure that they know how to get up if they ever fall. Going up and down stairs, they do this one time, just going up and down on their own. Then we have them carry groceries. So they go up and down, they go out the door, they go around a cone, they come back, they have to open the door and put the groceries on the counter. And this one to me is by far the most interesting thing. This is the only time in my life I have ever been hurt as the experimenter collecting data. And that is because I had this sweet little man who had these two huge things, and he went up the first step, and then he took this bag of groceries and came over here, and he swung them up over his shoulder, and he nailed me on the head, and then that's how he carried the groceries the rest of the time. And what was even more bizarre is when he got to the door, the groceries came down, and his foot came up, and he tried to open the door with his foot. So not only did I get hurt, but I got to see the Karate Kid at 90, and it was also really interesting because if Natalie was collecting the data from that individual, then she could have talked to him about maybe some ways that she should change her strategies from being 18 versus being 80. And then finally they do a 6-minute walk. So what we get from this is information about their upper body strength, lower body strength, balance and coordination, endurance, and flexibility. I have a typo. So, and when you think about how these apply to driving, does somebody have the upper body strength, to drive for a couple hours and hold their hands on a steering wheel? Are they going to have the strength to be able to move their foot back and forth from that gas pedal? Are they going to have the strength just to sit in the car for a couple of hours? So this really gives us an important perspective on somebody's functioning outside of the car. And then we had to develop reports for this too to be able to give to these folks. So this was a good example for us of having a ton of data and getting it to the point where we could put it on just a couple of pieces of paper and have it be very visual information. So I think one of the things from us from a driving perspective that was important was really figuring out what are those key elements and what are the most important elements to communicate to the patients and their families. The other thing that we're doing is developing smart nightstands, smart over-the-bed tables. Now, I'm sure you're saying, why in the world is a driving person looking at furniture? And the reason for that is we have all of these sensors in the car, and so we can tell if we had the ability to collect that data from these folks over time, how somebody's physical functioning is changing. And what we really need is to be able to figure out how we can do the same thing in the home environment and get the home to talk to the car and get the car to talk to the home and really be able to come up with a way to get that information to the clinicians so they can be more proactive when folks are having trouble. So one of the things that we see with older adults is when they're slowing down, they tell us they still get out and drive every day. In reality, they might drive once a week. So we might be able to pick up some of that information from the home environment before we would really be able to pick it up from the driving environment. So again, ultimately what we're interested in is how can we start getting the home to talk to the car and the car to talk to the home and vice versa. And now I'm going to completely shift gears and tell you about CUI CAR. So CUI CAR is the automotive engineering department that I work with, and it stands for Clemson University International Center for Automotive Research. And this is another one of these centers of economic excellence. So there's been a lot of automobile industries moved to the southeast in the last several years. So BMW is in Spartanburg, which is about 10 miles from where this campus is located. Michelin North America is there. Timken is there. We have a lot of Tier 1 and Tier 2 suppliers. And so we really, one of the problems that these industries are having is they don't have enough engineers to go work and fill the jobs. So what Clemson has built is really, we already have this research network that of our mechanical engineers, our civil engineers, our electrical engineers, our human factors folks. So we have this infrastructure already, but what we didn't really have was this core group to bring all these folks together within the transportation or really automobile domain. So we have 4 endowed chairs. One is with vehicle electronics, one's product design and development, manufacturing, it's Dr. Kerfis, and then systems integration, and the systems integration chair is really the one who glues all of these folks together. This is our building. It's been here for just a few years. It was completed in 2008. This is where the students live. So because of so many engineers are now in these very mobile environments, it's really the way that we have the student areas set up too. So the students usually move a couple of times while they're there depending upon which projects they're working on. We have a 7-road post simulator and climate test chamber. I think this is my favorite lab in the entire building because it just really cracks me up when it's 110 degrees outside and everybody is sweating to death to see the guy dressed up like the Eskimo to come out of this room in the middle of the summer. We have a coordinate measuring machine, a chassis dyno, a test cell, and really what we use all of those different labs for is a project called Deep Orange. And the entire idea of this program is it's just graduate students, it's automotive engineering, it's a master's and PhD program, is to really be able to build a product within this 2 years master's program. So they start off in the very beginning doing a market analysis of some type of vehicle. They build a different prototype vehicle with each class, and by the end of this, by the time they graduate, they have to have a working model. So our first one was designing a vehicle for Gen Y and really looking at the components of what's important in a vehicle to people your age. So the students transferred a 1 Series BMW into an extended range electric vehicle, and just about everything in this vehicle was completely different than when they started it. Some examples of that is they wanted to have seats that were mounted from the top rather than having all of that weight in the beginning. And so a lot of this process over this 2-year period is they were either on an interior team or an exterior team or the powertrain team, but the seat team, it took them really 9 versions of testing and prototyping before they got something that really worked. Because of the fact they have a seat that's mounted and permanently fixed, then they also had to really figure out how they were going to be able to move the pedals to the driver rather than moving the seat to the pedals, and then same thing with the steering wheel. One of the groups that they're working with is industrial origami, so it's just taking, instead of having all of this manufacturing time, how can they print out the materials that they need and literally fold them into place within an afternoon. And by the end of the summer, it's a kind of terrifying time when they're putting everything together, and what they ended up with was really a completely different vehicle than what we started with. So I think for us, one of the things that's really fantastic about this is it forces all of us to be involved in this process. So where Natalie and I are involved in this, are thinking about, okay, if this is designed for younger drivers, what are some of the issues that younger drivers see in the clinic and how different that is from our senior drivers? One of the things we've done with this over the summer was design a completely reconfigurable center stack and having something that's both going to be Gen Y friendly and also senior friendly. One of the things that completely shocked our engineers is we had 4 very different designs, and they thought that what they would end up using is one Gen Y design and one baby boomer design. It turned out that every group of participants ended up picking the same design. So, you know, having good usability principles, human factors, a lot of times will trump these other really cool technologies. So that has been really interesting, and I think just a good illustration of the importance of having these multidisciplinary teams. And I think that's it. Yep. Any questions?
Any questions? Please use the microphone so that we can record your questions.
You mentioned that on some of those slides about not that the seniors or someone did not want to use the simulators for testing their driving. Any comments on why that won't be? If we can train people to fly jet planes off aircraft carriers, I would think there'd be some overlap there.
Yeah, so I think where we really look at that is where is the technology right now? So who knows where it's going to be 20 years from now, but right now we just don't have the evidence, and it's hard enough. The driving rehab specialists have a hard enough time doing it on the road that we just don't have simulators today that are really, we're not ready. We're not there yet. Who knows in 20 years? And do you want to comment on that one?
I'll comment in that as a therapist, we're not, and what I think that a lot of therapists have a hard time looking at simulators doing this is that we look at the global picture. We're looking at everything that the person has, from their medical problems to certain disabilities, and kind of looking if other areas can compensate for some of those disabilities. And I don't know how much, you know, that's why I think for training definitely we see a whole lot of potential, and some people are using it as an evaluation tool and looking at it like that. I just think that there's a lot of work to be done in that area. Yeah.
Any other comments?
My question will be on the driving simulator.
Mm-hmm.
What kind of feedback do you give to the kind of like the person who sits on the simulator? Is that something that also related to the force feedback, something that a jerk or a turn when where the people actually experience a centripetal acceleration or something like that, or is that only a visual?
Yeah, that's a good question. So one of the things that we decided to do, so your simulator has a heck of a lot more feedback than ours, and we chose to go with very minimal feedback, and the reason for that is simulator sickness and the amount of adaptation it takes to get somebody to the point where they're comfortable with that. So because the therapists have this hour-long session, we definitely went in the direction of not having a lot of that feedback, because from the rehab perspective, it's not the most important thing. So again, you have to think about what is the purpose of what you're trying to do. So there's a lot of things that would make, from a research perspective, a lot more sense to use the simulator here than it would to use our clinical simulator. And I think that was really one of the lessons that we learned early, is the first simulator that we had was a lot bigger, it had a lot more feedback, but it just wasn't appropriate for that application. Yep, that's a good question.
I'd like to ask, have you been asked to testify in any congressional committee yet about proposed mandatory age limits for driving? And the reason I ask this, my parents live in Pennsylvania, and they are in their late 80s, and they are concerned that one of these days, Pennsylvania is going to decide that when you reach a magic age, you can no longer drive. So I'm just wondering, have you ever been asked to testify, or do you think that may be coming?
Have I been asked? No.
Yeah.
Some of the people that I work with are most certainly involved in that. Like at NHTSA, there's Kathy Seifert is the program manager for the older driver programs, so she's very involved in those. There's individuals from AARP, from AAA, from the Center of Disease Control that do, and there's a lot of people from the professional organizations that we work with the driving rehabilitation specialists and the occupational therapists, and that our field is very careful to have one person, and actually she lives in the city. Her name is Aylin Shull Davis. She's an occupational therapist. She used to work at Sister Kenny, and she is really the person who handles that for our entire field more than anybody else. So I think one of the things that's really nice about this field is being very careful of who is the spokesperson for all of us.
You know, I saw your presentation on the various functional performance tests you're doing. I didn't see anything related to what do you do to mitigate the problem. If I don't have range of motion, I can't turn my head as well, or as I get older, my peripheral vision drops, or I'm not able to judge oncoming speed of vehicles. Mm-hmm. Can you train people to improve their performance? That's my question.
That's what occupational therapy then, we refer them to come in and undergo therapy. And everything from, one thing that we have a hard time that we always tell them we can't fix dementia, but everything else we're really able to work with the people to find either compensatory strategies or to spruce up those, like reaction time is definitely something that I've seen most of my patients being able to increase their reaction time significantly by just, going through the therapeutic process.
Do you see there being a national fitness for driving test that could then be used to evaluate whether one can drive or not drive as opposed to age?
I'll let you handle that one. It'll be interesting to see what happens. And it'll be interesting to see what happens in different countries, too. So I think each country is handling that very differently right now. It's handled very differently in Europe, where there's a lot more mandated training at a younger age. So the way it's handled right now, and I think kind of maybe the best way to handle that is we'll have Natalie kind of walk you through the process of, if you're concerned about an older driver, what those steps are and how most states handle that. And because in the United States, let me think about how to politically correctly answer this one. I think because of the way that our country is set up, and if you think about who is always voting, which legislator is going to be the person who passes that kind of a bill? And I would have to say that since I've been doing this research, I think the fitness to drive issue is not an age-specific issue. There are a lot of 77-year-olds and 87-year-olds and 97-year-olds that I would rather drive with than a 27-year-old or a 17-year-old. So I think that there's definitely issues that you face as you age that makes it more challenging. But I think that there's good drivers out there, and I think that there's bad drivers out there, and I think, unfortunately, a lot of times seniors have a really bad rep because one senior will do something that is not very smart and it makes national headlines, but you have 17-year-olds do stupid stuff all of the time, and it's so common, nobody hears about it. But I do think having Natalie kind of walk you through that process is really interesting on how it works with the
I'd
referrals.
have to say, for us, we've worked really hard with physicians in our area to help people come in before there's a problem or a big problem. So we're trying to do on the front end and having the physicians refer to the driving health inventory, which he talked about, that computer program where we can then track changes that they have through their therapeutic process. So they come in, we'll do an evaluation like that and work on some of those abilities, and they'll continue driving during this time, and they're not yet at a point where we would recommend either restrictions or cessation of driving. So it's kind of a good way to work to keep people safer longer. Yeah. And that's been with working within our area with those physicians and getting people, family members, involved more. Yeah.
I know people have other things on their schedule. We're only scheduled to go to 4:30, so I just want to thank our speakers for a very entertaining presentation and absolutely very illuminating presentation. So thank you very much, and please join me in thanking our speakers. And the next seminar will be 2 weeks from today, and I'm trying to remember what it is. John Erdos, okay. An observational study of pedestrian and bicycle crossing experience in 2 modern urban roundabouts. John Erdos, September 29th. We'll see you then.